Hey everyone, my name's Omar. I'm one of the family med residents over at Full Circle in Boise, one of the third years. Um, I am going to be talking today about Suboxone in primary care, and then a little bit at the tail end just about pain management and best practices and kind of some things that are on the horizon for pain management, including with Suboxone. But I wanted to kind of take a step back and give a very broad overview of where we came from, where we're headed, and kind of bigger picture stuff as well. So I'll go ahead and get started here. Um, I have no current financial disclosures to report. And briefly to go through goals and objectives, discussing a little bit about terminology, um, looking a little bit about historical context regarding substance use disorders, talking about epidemiology, and then talking about clinical manifestations as well. Wanted to just give a big picture overview about induction options, including the micro dosing versus a standard induction. Um, Hoping to explore a little bit about comorbidities, systemic health effects, screening tools, physical exam findings, and then best practices for assessment, thinking about BUP for pain, FDA-approved methods, and then the role of family medicine in supporting these patients. I think my big picture disclaimers are that I'm not an expert in this at all. I think it's important to keep in mind that opiate use disorder is a long-term, chronic, relapsing and remitting course, similar to hypertension and diabetes, and our patients deserve compassionate, evidence-based care regarding this. Okay, so I wanted to start off. I have some notes here. They're on my phone, so if it looks like I'm reading off a screen, that's because I am. And talk a little bit about terminology. So we kind of separate opiates into three major categories. The first one are opioids themselves. So these are natural or synthetic substances that act on opioid receptors, so mu, kappa, delta, and nociceptive receptors. Um, and then we have opiates, which are alkaloid compounds, so morphine and codeine. And then we have synthetic opioids, so hydrocodone, oxycodone, fentanyl, and methadone. We have semi-synthetics in the middle as well. So I think it's helpful just to kind of keep a schema in mind and helps you orient to where you're at. Moving on to epidemiology. I think this chart, I'm sure we've all seen one that's very similar to this or, describing similar data. The prevalence of opiate use disorder is significantly higher in the United States, especially when compared to the remainder of the world. And I just wanted to talk through some brief numbers real quick, which I found to be like fairly impressive. So 6.6 million Americans, so 2.3% reported heroin use in their lifetime, and 709,000 Americans reported heroin use within the last month. 1.6 million Americans had a history of illicit fentanyl use at any point in their lives, 330,000 within the last month, and 8.4 million Americans. So, and this was in a survey for folks who were greater than 12 years old, had a history of a misuse prescription, especially for painkillers within the last year. And risk factors that they identified when they were doing these surveys are a history of a younger age at first exposure, a history of concurrent substance use of any kind, a history of severe pain, and then comorbid or co-occurring disorders, which oftentimes is taken to mean psychiatric-based disorders. A couple other slides about epidemiology. There have been globally three major waves, and I really like this chart from the CDC. It helps outline wave one, which started in the 90s. This was the prescription opioid overdose deaths. And then wave two, where we had the rise of heroin, that was in the 2010s. And then synthetic opioid deaths, which is what we commonly refer to kind of as the fentanyl era, which started in 2013. And I think what's really interesting about this is noting that the synthetic opioids have had, in their deaths per 100,000, have had a significantly higher impact, especially because they're oftentimes laced with, or other substances are laced with synthetic opioids, which lead them to be very lethal, especially when patients don't know what they're getting and, if they don't have fentanyl test strips or things of that nature. And then heroin kind of had a little bit of a bump, and then it's sort of on its way down. And then the commonly prescribed ones, so oxycodone, hydrocodone, those sorts of things have been generally fairly flat. But when looking at this graph, I think seeing that fentanyl has had a huge driving force in this is pretty marked. And then these are just metabolites here. So heroin moving to 6 MAM and then breaking down to morphine and then the morphine metabolites as well. Okay. Um, I think this slide is really helpful. I oftentimes, especially when I have a patient who is contemplative and willing to engage and is thinking about sort of what do these next few weeks to months look like for me, especially as I decide that I want to transition to something like Suboxone. I like to discuss with them kind of things that we're looking for and things that we're worried about. And so I walk through this slide with them. And so I wanted to touch a little bit kind of on the different body systems that I think about. So certainly the brain, right? Thinking about opioid receptors, cardiac stuff, which we'll get to a little bit, arrhythmias, hypotension, heart failure, but also thinking about endocarditis being one, especially if folks have a history of IV drug use, stomach issues, whether that's opioid bowel syndrome or nausea and vomiting, decreased stool, and then having diarrhea in the interim. Thinking about lungs as well, people can be at a higher risk of pneumonias, can lead to hypoxia and asthma symptoms. And then here they outline kidneys as well. I think other signs and symptoms, things that I kind of look for clinical consideration. So when evaluating a patient, thinking about slurring of speech, thinking about sedation, pinpoint pupils, and residual injection sites. And then keeping in mind that folks that have higher tolerance levels may not necessarily present with these signs and symptoms, but will certainly have signs of withdrawal, especially as they go through, say, a hospital course or for whatever reason are detoxing, like postoperatively, et cetera. Thinking a little bit about severe disorders, I think when I was doing research on this topic, I found this to be fairly interesting. So, a history of high risk and illegal behaviors, for instance, shoplifting, burglary, prostitution. Oftentimes, these are the sole drivers of financial support in support of the habit. And then the substance use itself can become just an organizing feature of daily life. So, there was a couple of reports and conversation online about providers worrying about behaviors being secondary to a psychiatric disorder, such as antisocial or sociopathic behavior. But a lot of the data shows that once folks are engaged in treatment, a lot of these behaviors tend to return to what we would consider quote unquote societal norms. Essentially saying that these behaviors are more in line with the addiction component than it is a genuine psychiatric component. I think this slide outlines very similarly to the last one, kind of just thinking about different parts of the body that can be affected by this. So I like to classify it in big picture infections, and that's kind of the first bucket that I have. So thinking about cellulitis, abscesses, endocarditis, HIV and hepatitis, especially depending on the mode of ingestion. Then I think of systemic things like we talked about a little bit earlier, opiate use disorder, bowel syndrome, GI motility concerns, early satiety and pain. Thinking a little bit about hyperalgesia. So this can be severe, can be chronic, can be recurring. And then thinking about hepatic fibrosis as well. And there's good data to support that independent of other infectious symptoms, folks with opiate use disorders tend to have higher rates of hepatic fibrosis. And then overdose risks. I think that kind of falls into the neuro/psych camp for me. And mortality is 63 times higher in untreated heroin users when adjusted for age and for sex as well. Oh no, my little bullet points didn't come through. They're just little squares. Screening. Screen all patients. I think it's one of those things. We talk about tobacco, we talk about ethanol use, we talk about getting a colonoscopy and making sure mammograms are up to date. And I think discussing opiate use disorder is really important as well. So I think there's certain patients where it should jump out to us that we should be thinking about this. And I've had those listed here. So folks that have had a history of endocarditis, bacteremia, skin abscesses, vertebral osteomyelitis, HIV or hepatitis, I think very reasonable to bring this up as a screening question. And there's a couple of tools that I've listed here. The current opioid misuse measure, opioid risk tool, and then oftentimes even just going through the DSM criteria and seeing if folks meet those. So I pulled up the DSM criteria here, and I wanted to call out just a couple things. So I think what stood out to me was continued opioid use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of opioids. I think when I think of function, that's not one that normally comes to the front of my mind. And then tolerance. And tolerance is one that I think can be more insidious than the big glaring one. So markedly increased amount of opioid to achieve the desired effect, and then continued use with a diminished effect. Both of those hand in hand, I like to try and probe when I'm talking to patients about that. And then withdrawal, I think, is obviously something that can help guide us towards the DSM criteria. Okay. Lab evaluation, depending on your clinic system and depending on the urine drug screens that you have, most of the time a UDS for infrequent morphine and heroin usage will show up for about 1 to 3 days. For folks that have a more chronic use, it can certainly persist longer than that. There are specialized tests that your clinic system may or may not have for methadone, buprenorphine, and fentanyl as well. I think at Full Circle we have fentanyl urine drug screens, but somebody who's on here can correct me at the end if I'm wrong. Things that cause false positives, which I just always find to be interesting. Rifampin was one that I read, which seemed kind of cool. Quinolones, also very interesting. And then kind of the classic one is poppy seeds, which, yeah, I just think is a fun bit of medical trivia. Other tests that I like to get, especially when I'm broaching this with patients, is talking to them about ordering a CBC, talking to them about ordering LFTs. Oftentimes I will just get the full CMP. Talking to them about HIV screening, making sure they're up to date, when their last one was, any history of treatment. Hepatitis screening, kind of the same thing, making sure that they're up to date on any immunizations, any history of treatment, Hep B, Hep C, those sorts of things, and then treponemal antibody as well. And then I think plus minus on the rest of STD and STI panel, it's kind of dependent on the patient presentation and kind of individual risks. And then I think depending on the mode of ingestion, for example, so if someone's got a history of IV drug use, reasonable to consider getting an echo, especially if your cardiac exam leans you in that direction. So kind of just thinking about the whole patient and what could be impacting them the most. Talking a little bit about assessment. So kind of questions that I like to pull into my charting every time I talk to patients about opiate use disorder, pain management, kind of any of these things. I always like to ask about other substances. That's including nicotine, that's including caffeine, and then obviously ethanol, marijuana, other IV drug use, history of drug use, frequency, duration, those kinds of things. I like to ask about the primary route of ingestion can be helpful as well, just to help risk stratify some of those previous things we discussed. I like to talk about concurrent legal issues. I know that that can be difficult for patients to talk about and difficult for providers, physicians, kind of all the above to broach a little bit, but it helps give me clinical context to this person. And if there are other people that need to know that they're engaged in treatment, those sorts of things. Some folks will be in drug court. I like to ask about a history of treatment, and then kind of within that bucket, what were some successes? What were some failures? Was it medically supervised? Did you take any medications for maintenance? Was this inpatient? Was this outpatient? What was the longest abstinence that's achieved as well? I like to talk about comorbid psychiatric conditions, so anxiety, depression kind of being the big two. Also thinking about bipolar disorder, schizophrenia, kind of the whole gamut, but certainly at least getting a baseline for them, and then reasonable to order a PHQ and a GAD and get a baseline for folks as well. I ask about the age at first use. That can help sort of clue me into what are going to be some other factors for me, and how difficult, kind of what is the burden on this patient's life is the way that I characterize that. Um, for my physical exam, I check for calluses, scars secondary to injection sites. I check interdigitally, toenails, axilla, breast, lymphadenopathy posteriorly, thinking about possible HIV, hepatic enlargement, thinking about acute hepatitis. And then if I have a small or nodular liver on exam, thinking about chronic hepatitis. So, kind of transitioning here a little bit, talking now about buprenorphine, we'll kind of move into what are the major induction protocols that folks either worked with or have tried, and what does the FDA talk about? But I want to take one step back and just kind of talk big picture about buprenorphine and kind of who is the candidate that we think about this for. So, thinking about baseline function, I like to probe a little bit about how pain is impacting the individual. And this can lead to a wide variety of answers. I think it's super helpful to document this. That way, as their relationship with their provider progresses, you can ask, how has this pain changed for you? Are we still meeting those same goals for you? Or kind of what has the delta been since your initial evaluation? I also like to ask, are current opiates working or not? And sometimes patients will be on increasing doses and it's still not getting them to the pain level desired. So are they a good person that buprenorphine could work for? I like to ask pain-related function. Are there certain maneuvers that make it worse? Are there certain times of the day that make it worse? Thinking about possible rheumatologic conditions, thinking about physical functioning, those sorts of things. And I think really important is getting buy-in from patients. So really establishing we're in agreement that either the opiates are no longer working and they're no longer benefiting you, or they're actively causing harm. And I think that patient buy-in is probably one of the most important things when thinking about buprenorphine for pain management. So let's talk a little bit about who is an appropriate candidate. I think folks who have made limited progress towards an analgesic goal, especially with a full mu agonist, um, folks that having access to full mu agonists for behavioral health and mental health reasons could be at a higher risk for adverse events. Those are candidates that I tend to think like, okay, this is somebody that I could consider this on. I think people who are not appropriate candidates, and certainly uh, everybody's going to have their own different flavor of this, but if someone is using pain medicine infrequently and it's an immediate release pain medicine in an episodic fashion, this is not somebody that I think should be transitioned to buprenorphine. And if someone is requesting a taper off of their current, like oxycodone, for example, the current clinical guidance is it's better to taper off using the existing opioid than transitioning to a different one, which was something that I learned while I was doing research for this. Currently the transdermal and the buccal buprenorphine are FDA approved for this, and it takes about 5 days to achieve a steady state. So I think talking to patients about that and letting them know that this isn't something that's going to just kind of kick in right away. It's going to take some time to build up a baseline in your system. I want to pause right there. Does anybody have any questions about anything so far? That sounds good. Going. Okay, method number one. Um, this is kind of the traditional method is the way that I see it described very frequently. This is also known as the stop-start method. And so essentially the idea behind this is you stop your full agonist depending on what it is that they're taking, but roughly the data is supported for 12 to 24 hours in advance. And then once their CAL score begins increasing, just move it. Okay. Once the CALS score begins increasing, and the number that's often cited is 12, and I have an example of the CALS scoring a little bit later in my slides. Um, then the addition of buprenorphine is reasonable. The benefits of this are decreased risk of precipitated withdrawal, and kind of the way to think about it is if it is going to help a patient with their pain, quick recognition of that. So it'll have an effect, and then the patient is able to say, I feel a little bit better. So I think this is largely the schema that we had been using for quite some time. These are from the Opioid Response Network. I really like these. And so I'll kind of walk through them because I think they're super helpful. And this is regardless of if you're doing a transition from an oxycodone, like someone with chronic pain moving to Suboxone, or somebody who has an opiate use disorder and is moving to Suboxone. So this uses the strip or the tablet as its example, but you can print this out and you can send patients home with this. And so they can sort of do this at home. Putting the 4 milligram strip under their tongue, don't swallow it. Keep it there for approximately 15 minutes. Check in at 1 hour, and this would be a self check-in if they're doing this at home, or some clinic systems have the patients stay in the clinic system for that initial induction. And so that's very reasonable as well. And if you still have some feelings of withdrawal, which are kind of listed on the next slide there, then put the remaining 4 milligrams under your tongue. Then they do a 6 hour check. You can see how you feel again. If you're having withdrawal feelings, take another 4 milligram dose, and then do not take more than 16 on the first day. And I like this because it really just helps normalize like numbers for patients too. Like most people feel better at 4 to 12 on their first day, but if you still feel really bad, you should return to the ER. I think that's great. It helps outline symptoms that I would be telling patients to look out for. And then there's an induction visit procedure as well here. So if your clinic has the option to do this, this is really nice to have. The next one is fairly similar, just information is presented in a slightly different way. So depending on your patient population, I think either one is totally fine. This one can be on a card, which I really like. This one is a series of cards. So first dose being the 8 milligram, cutting the full film in half. That's your first dose for 4. And then talking about the different symptoms to be watching out for. And here they say 24 to 48 hours. So I think, once again, very dependent on the medication that the patient's on. This then moves into the day 2 here. And so it gives a couple of different options. So if you took 4 on your first day, which would have been here, and you felt fine in the morning, then take 4 milligrams as your day 2 dose. If you took 8 on day 1 and you felt fine this morning, then taking 8 as your day 2 dose. And then it gives a couple of contingencies as well that patients can kind of walk through if needed. And then this is the California Bridge, the Treatment Starts Here program. They have a couple of different pamphlets. I also think very highly of these. One of them is the emergency room induction protocol. One of them is the at-home protocol. But this, once again, walks through very, very similar information. I think something that I was faced with the first time I did this in residency, I had not told a patient to take a day off. So I would recommend that when people are doing the start-stop method, very reasonable to encourage patients to have a day off, to be home, and kind of have a quiet environment and not be trying to do this while they're at work and I'm on my ER rotation. So yeah. Telling folks not to drive, trying to avoid other substances as possible, and then same thing. And at the bottom here, the reason this one's really nice is call or text if you've got navigators at your clinic system. And then it talks about kind of what next appointments, what those timings are. Okay. Induction method 2. This is the micro dosing. I think I was reading on UpToDate, and maybe somebody's on this call who knows a little bit more can correct me if I'm wrong, but UpToDate seems still to stay away from this a little bit. Curbsiders, other resources tend to say that this may be moving into favor a little bit, so maybe it's just in a flux period right now. But essentially, the idea here is you start a very low dose of the buprenorphine, so 0.2 to 2 milligrams sublingually, and you continue the full agonist. And so the idea here is that there's less of the withdrawal symptoms and the discomfort that can come with that. And then there's two different ways that people taper opioids. Either they do it gradually over 5 to 10 days, or there's an abrupt discontinuation on day 8. I saw a bunch of different things when I was reviewing this. It's also called the Bernese method, which I think is just a fun name for anything. So this is from the VA. Actually, they've got a fantastic, it's like a 6 to 12 page document kind of outlining best practices, especially for chronic pain. Um, but I think this is really good kind of to have in your back pocket as you're thinking about what are steps and kind of what are my options for a patient. And so MEDD being morphine equivalent daily dose, and then calculating out either using calculator on MD-Calc or whatever your preferred option is. And here they talk specifically about the FDA approved ones for pain. So the transdermal, and the buccal products. So if you're on less than 30 milliequivalents, morphine equivalents, sorry, you treat them essentially as opioid naive, and the patch is the preferred one. This is per their guideline. And I recommend 5 micrograms as that starting dose. If you're at 30 to 50, considering 10 micrograms per hour patch is the initial dose. And then onset may be delayed up to 24 hours. So you can overlap that full dose for 24 hours. The FDA conversions to bupe are highly conservative. And so just keeping that in mind as you're swapping from one formulation to another. The 50 to 90 morphine equivalents, so all buprenorphine formulations, micrograms or milligrams available based on patient response. So this one then goes to talk about pore function. You can add consideration of milligram formulations with a focus on early stabilization of withdrawal symptoms, and then a titration from there, which I personally haven't done, but I think is a very interesting option for folks. And then people tend to stabilize on a lower dose than are required for an opiate use disorder. And then the last one, I really wish I could do this. Oh, maybe that works. For greater than 90 morphine equivalents, very early emphasis on mitigating the withdrawal and discomfort during the transition. I think the verbiage behind this really helps emphasize that this is going to be a patient who may have a very uncomfortable withdrawal. And then you can consider the stop start, or the low dose buprenorphine induction. The VA is fantastic. I would highly recommend it. It's linked at the end of my PowerPoint as well. And then this is from the treatment of opiate use disorder. I feel like I've seen this graph in a bunch of different places, and it's helpful to talk through patients. I will pull this up, and it kind of outlines what you're doing on each day, kind of outlines what your goals are going to be when you start tapering. So I'll kind of talk through this real quick as well. So this is from patch to sublingual buprenorphine, from opioids, oxycodone, hydrocodone, morphine. So we're starting on day 1. We start the transdermal patch, and they're on their full dose of the regular opioid as well. Day 2, this one recommends starting the taper. And then on the right side here, where it says buprenorphine patch dosing, it talks a little bit about the different patches that you can use, the different strengths depending on the morphine equivalents, which I think is really nice. And then tapering the opioid as needed. Here they use clonidine as an adjunct, and then reducing by 50% on day 2, stopping by day 3 or 4. And then you can start your sublingual buprenorphine on day 3 and gradually increase as well. And then it tells you kind of your prescription, what you should be starting on. So the buprenorphine naloxone 2.5 and 30 of those. So all that to say, I think that this graph is really helpful to sit with patients and kind of walk through what you're doing in a stepwise fashion, so there's not any surprises. Okay. We're gonna talk a little bit about non-opioid modalities as well. I think I like to chat with patients about supportive things, and so I kind of start from the top. I make sure that if they've had recent imaging, what has that imaging showed? Have they had lumbar x-ray? Do they have glenohumeral joint issues? Kind of let's take a step back and figure out what are we really dealing with here. I review that imaging with them, try and understand it a little bit more. history of trauma, history of chronic injuries, what does work look like for you, those sorts of things. If physical therapy is indicated, very low threshold to reach out to our physical therapists and have them kind of assist us with this. And then occupational therapy as well. There's an emerging field, which I guess maybe is not super emerging anymore, but pain psychology, talking about cognitive behavioral therapy and motivational interviewing, trying to understand how people can anticipate pain and then do maneuvers to try and complement that or try and suppress that painful motion. Thinking about interventional procedures, so trigger point injections can be helpful, joint injections if clinically indicated. There's some data, which is anecdotal at best, regarding acupuncture, but I think very reasonable to consider in patients. Thinking about NSAIDs, if they're able to tolerate that, can be helpful as well. And then for folks who have neuropathic pain, thinking about SNRIs and gabapentin as well, which I think if you've got a patient who's got concurrent psychiatric stuff, can be helpful, but if they're clinically stable on their psychiatric meds, adding other like venlafaxine or something may have the risk of causing worsening symptoms. And so reaching out to your local psychiatry colleagues and seeing how they feel about addition of those medications. Muscle relaxants can also be helpful. I feel like I don't see that too frequently. We see it a lot in the inpatient setting. I think the pain service at St. Al's does a really good job of kind of doing a multimodal approach with patients. And then depending on the patient and kind of how into complementary or integrative stuff they are, things like yoga and Tai Chi can also be helpful. So talking to them about that. Um, I don't know if any of you have ever Googled breakthrough pain, but there are some absolutely hilarious images that are also graphs regarding breakthrough pain, and I thought they were so fun. I picked one that was purple, but highly recommend looking at Google images for breakthrough pain. So you've got a patient, they're now on buprenorphine, and they're having some breakthrough pain. What do we do? So this is guidance from Curbsider's episode through the Addiction Medicine podcast series, which I have linked at the end of my PowerPoint as well. And the doc who was there tended to recommend that it is reasonable to consider adding a full agonist if there's no co-occurring opiate use disorder. And kind of talked about, which I hadn't considered this. So I thought very interesting, and I'd be interested to try it and see kind of what the efficacy is. But adding a full agonist should not precipitate withdrawal, and a patient may gain analgesic effect with it. And that doc on Curbsiders seemed to hover in the oxy 5 milligram to 10 milligram PRN mark, which that was interesting. If anybody's got any experience with that, I'd love to learn more about that. Okay, so coming kind of up to the tail end here, I think things that are important, the role of family medicine physicians, the role of addiction medicine, psychiatrists, kind of everybody in the healthcare system. So oftentimes primary care, we're the glue between inpatient, outpatient specialists, making sure we're doing routine screenings, diagnostics, following labs, and assessing clinically frequently. I think physical exam findings can be super helpful just to make sure that we're not missing something from a health standpoint. So murmurs, small nodular liver, large liver, thinking about those kinds of things, posterior lymphadenopathy, et cetera, et cetera. I think management of comorbid conditions, having the awareness to screen. Advocacy is really important in this realm. The harm reduction program here in Boise recently, I guess not super recently, but is currently inactive. And so advocacy regarding harm reduction strategies, and then non-judgmental evidence-based care. And then I wanted to talk pretty quickly, opioid dependent patients with chronic pain on a scale of 0 to 10 had a 2.3 point reduction when converted to sublingual buprenorphine, which is just fantastic. Other benefits of it include increased efficacy for neuropathic pain, ease of dosing and usage in elderly patients, and then there being a ceiling effect on respiratory depression. So all very, very positive things regarding it if it's for the right patient. Next steps for folks who are interested in learning more about this or have more questions, I would say the Curbsiders podcast on this, number 15 for Addiction Med, was very helpful. And I think is very, you can put it on while you're folding laundry or, going from point A to point B between clinic sites. The VA DoD practice guideline, which I referenced a little bit earlier in my PowerPoint, can be tremendously helpful as well. The Bridge to Treatment Guide, which is probably the most popular. That was the one that had the infograph and then had a sublingual pill underneath the tongue. I think they've got fantastic resources for inpatient, outpatient, emergency room, self-induction, those sorts of things. And then SAMHSA has a buprenorphine quick guide, which I also think is really helpful. Likely will depend on your practice style and will also depend on the patient panel that you serve. So, okay, that was a lot of information. And my mouth is kind of dry from talking that much. So, questions about things.
How is insurance coverage for these? Because it seems like that's been a big problem with getting coverage and costs.
No, I appreciate that question, Dr. Esplin, and I will be totally transparent. I do not know. Hopefully good to medium, but I don't know. If anybody else has a better understanding, feel free to chime in. Elaine said Idaho Medicaid will cover all buprenorphine products. Great. Thank you, Elaine. Other questions?
I have a question, Dr. Syed. In from your kind of review of the literature on using Suboxone for pain management in primary care, like how would you rate the current evidence? Um, like are these practice guidelines and decisions based on robust evidence, or like would you give it a plus, B, a C minus? Like what would you say in general?
Yeah, I think that's a good question. Thanks, Dr. Garish. I think from everything that I saw, it seems that the data that is out there is good, and it seems encouraging, but it is not necessarily being utilized quite as much as it could be, and it's very dependent on the specific patient. I think you have to have a specific patient who is willing and able to engage in this that it's good for. So I think it's more to come is the way that I would say. So if I had to grade it A through F, I'd give it C plus plus B minus.
Okay, cool, thanks. And pain psychology isn't that new.
Should have said I should have said new to me.
Love it. Thanks for the talk.
Yeah, great. If nobody else has any other questions, I'm currently on call today, so I'm gonna skedaddle, but I'm very appreciative of all of your time and I'm happy to discuss more about this offline. Um, yeah, great. Thank you all.